Hi, everyone. Today, we're excited to share some outcomes and recommendations stemming from a recent research effort on bed capacity tracking for behavioral health providers in Colorado. My name is Abigail Fisher, and I use she, her pronouns, and I am one of 3 human-centered designers at the BHA. Human-centered design is a mindset, skill set, and process that helps put people and their needs at the center of our work. My focus is specifically on provider services and technology, ensuring that we collaborate with Colorado behavioral health providers in the creation and improvement of technologies and services. Today, I want to talk with you about how we engaged in conversation and research with providers across Colorado to better define what bed capacity tracking means in our state and what resources, processes, and technology systems we need to put in place to move this work forward. One of the main questions we asked ourselves and providers throughout this process was how might we balance reducing administrative burden while also creating systems that improve transparency and equity for people seeking behavioral health care in Colorado. This quote from a quality assurance professional at a residential SED facility, substance use disorder, does a great job of demonstrating what pressures providers are under and how administrative burden adds to that difficulty. The quote follows: "Our industry isn't just in a labor shortage, it is truly a crisis. We're losing staff left and right to private practice where the documentation requirements are much more lax and the pay is much higher, but we are not finding replacement staff. We've had to shut down several offices because of this labor crisis and are about to close more offices. So to be blunt, data reporting to the state is nowhere on our list of priorities because we are just trying to stay afloat and keep the doors open." The goal of our research was to better understand and ultimately recommend how behavioral health capacity tracking could improve care, coordination, and access for the people of Colorado while balancing this immense administrative burden that we know providers are experiencing. To do this, we conducted seven interviews with peer states on the tools used and processes involved for bed tracking. We also spoke to a total of 13 subject matter experts, both from BHA staff and other core potential user groups, folks like the mobile crisis workers and crisis hotline workers. We conducted 6 in-depth interviews with providers working in facilities with BHA licensed beds. And we finally conducted a larger system-wide survey, which we received 102 responses, reaching a wide swath of providers from frontier, rural, suburban, and urban areas of Colorado. Across our research, 4 key themes emerged. The first being that capacity is not a simple number. A provider's capacity is a judgment call that depends on rapidly changing and hard to document factors about both the patient and the provider. Next, capacity data is only useful if it is both granular and accurate. But providing granular and accurate data is incredibly time-consuming for providers. Providers are overburdened, understaffed, and suffering from already high administrative burden. And finally, the stakes are high. Gaps in care coordination, delays in treatment, and unsuccessful referrals lead to poor patient outcomes in an overburdened emergency department. We learned a lot from this research about the current referrals process and how it can lead to inefficiency, longer wait times, and unequal treatment availability. One executive director from a substance use disorder residential treatment and detox center told us, "We absolutely pour our heart and soul into finding treatment for someone suffering, only to not hear back from the 30 to 40 resources we've phoned. We trained our staff, don't wait to hear back, call them again." When providers feel they have run out of options, they resort to fax blasting, lengthy patient-specific referral packets sent to all providers that they can find. These packets are anywhere from 30 to 50 pages long, take time to create and read through, and are sent to many providers who would never be able to accept the patient based on their own eligibility and acceptance criteria. Cherry picking is when providers pick which referrals to accept based on perceptions about people who will provide more payment or be the least hassle. As a result, some people in Colorado are systematically edged out of care. And another trend is patient offloading, when a provider has a client they don't want to serve, so they offload them on another provider. Both patterns can negatively affect provider-to-provider trust. This diagram demonstrates how this inefficiency can stretch across 2 to 3 days until an appropriate facility can be identified. This means that people seeking care are waiting too long, too many inapplicable packets are being sent, and finally, too many inapplicable packets are being received. Our research indicates that a future state could shorten this wait time through the creation of a referrals matching tool, where providers are able to match a person seeking care's needs with only eligible for providers. This type of system would also eventually include capacity information to make the list of eligible providers for a specific individual's needs even more accurate. In short, this would mean that there is a potential for shortened wait time for people seeking care, that packets are only sent to applicable providers as vetted by a standardized system, and that facilities only receive applicable packets for review. This would also mean that the state and providers would have better information on why placements are denied, hopefully leading to greater transparency around care equity. We also learned a lot from other states with capacity and referral systems about best practices and what benefits providers have seen with the use of similar technology. Some best practices for this type of system include streamlined data entry, making space for nuanced data, disaggregating bed types, having a responsive, dedicated state team, automated email and text reminders for providers, creating space to collect and respond to feedback from providers on the technical system, and exploring automations with EHRs. Some benefits that providers have seen from similar systems are discovery of new providers not previously known before, generating reports, which is useful business intelligence for administrative staff, reporting provider data leading to the state providing support or targeted interventions, and finally replacing a worse or an antiquated system. These findings ultimately led us to 4 key recommendations that are currently in the process of being implemented by the BHA. The first recommendation is to treat capacity tracking data as one part of an overall behavioral health navigation hub with 3 components. We'll begin by creating a provider services directory where we can explore efficiencies to the referral process. Next, we will build in capacity data input, test this with a pilot group of providers, but not fully release the requirement until we create a robust referrals matching platform as previously described. We will use a phased approach for both implementation and rollout to learn from the process and to build trust with providers. We will continue to prioritize providers' time, effort, and usability because without easy daily engagement, we know the system will not be successful. And finally, we will leverage integrations between various components of the BHA tech portfolio as opposed to creating a siloed tool. This draft data model shows the type of information that you would be able to see on another provider in the system, drilling down to the unit level to give better and more standardized picture of appropriate care levels for the person seeking care you are trying to place. So what does that mean about immediate next steps? As I mentioned, we will begin the build of the provider services directory and simultaneously do additional research to learn more about how to standardize unit and capacity level data. We will also conduct a dedicated referrals research project. And finally, in the future, we will look at what information might be appropriate to surface to the public through a tool like our public provider directory OwnPath. Thank you for listening, and reach out to me at abigail.fisher@state.co.us if you have any questions or want to be contacted for future research efforts. Thank you.